Welcome to this course on Patellofemoral Pain Syndrome and Evidence-Based Update. Over the next several hours, we're going to take a comprehensive deep dive into one of the most prevalent and challenging musculoskeletal conditions encountered by rehabilitation professionals. Despite decades of research, clinicians continue to grapple with questions regarding optimal assessment strategies, treatment selection, and prognosis prediction. This course synthesizes the most current evidence from 2022 through 2025, providing you with practical, evidence-based strategies for managing this complex condition across diverse patient populations. This course is structured around 7 integrated modules that progress from foundational epidemiological and pathophysiological concepts through clinical evaluation, biomechanical assessment, conservative management strategies, population-specific considerations, and outcome measurement. Each module builds upon previous content while maintaining clinical applicability as a standalone resource. The final module presents case studies that integrate concepts across all domains, reinforcing clinical decision-making skills. Before we dive in, I want to emphasize something important about how our understanding of patellofemoral pain has evolved. Recent advances have shifted the paradigm from a purely biomechanical model toward a biopsychosocial framework that acknowledges the interplay of structural, functional, and psychological factors. This course reflects that evolution, incorporating evidence on psychosocial contributors, digital therapeutics, and individualized treatment approaches. Special attention is given to sex-specific and sport-specific considerations, recognizing that patellofemoral pain manifests differently across populations and requires tailored management strategies. Let me outline the learning objectives for this course. Upon successful completion, you will be able to analyze epidemiological data and pathophysiological mechanisms of patellofemoral pain syndrome to identify modifiable and non-modifiable risk factors across diverse populations. You will be able to apply evidence-based clinical examination techniques and diagnostic criteria to accurately differentiate patellofemoral pain from other anterior knee pathologies. You will integrate biomechanical principles with functional movement assessment to identify kinetic chain dysfunctions contributing to patellofemoral loading abnormalities. You will synthesize current evidence for exercise therapy, manual interventions, and emerging treatment modalities to develop individualized, multimodal treatment programs for patellofemoral pain. You will develop tailored rehabilitation strategies addressing the unique biomechanical, developmental, and psychosocial factors affecting runners, adolescents, and female athletes with patellofemoral pain. You will implement validated outcome measures and evidence-based return-to-sport criteria to objectively monitor treatment progress and guide safe return-to-activity decisions in patients with patellofemoral pain. And finally, you will apply comprehensive clinical reasoning to complex patellofemoral pain presentations, integrating epidemiological knowledge, examination findings, biomechanical assessment, and evidence-based treatment selection to develop individualized management plans. Upon completion of this course, you will be equipped to apply current evidence in clinical practice, critically evaluate emerging research, and deliver patient-centered care that addresses the multifactorial nature of patellofemoral pain. The content aligns with best practice guidelines and consensus statements while highlighting areas of ongoing investigation and clinical uncertainty. Let's begin with Module 1 on epidemiology, pathophysiology, and risk factor profiles. Patellofemoral pain represents one of the most common musculoskeletal complaints presenting to primary care and sports medicine clinics worldwide. The condition accounts for approximately 25 to 40% of all knee problems evaluated in sports medicine settings, making it the single most frequent diagnosis among active individuals seeking care for knee-related symptoms. Understanding the true burden of this condition requires examination of incidence rates across different populations and healthcare settings, as prevalence estimates vary considerably depending on the population studied and diagnostic criteria employed. Let's start by examining incidence in primary care settings. A comprehensive retrospective cohort study examining patellofemoral pain in Dutch general practice provides valuable insights into the condition's presentation in primary care. Van Leeuwen and colleagues analyzed data from over 300,000 patients and found a mean incidence of 3.4 per 1,000 person-years among individuals aged 7 to 24 years. This figure translates to approximately 1.4 new cases per year for the average general practitioner, underscoring the frequency with which clinicians encounter this condition. Notably, the study revealed significant sex differences in incidence rates, with females demonstrating nearly twice the incidence of males. Specifically, the incidence was 4.6 per 1,000 person-years in females compared to 2.3 per 1,000 person-years in males. peak incidence occurred at age 13 for both sexes, coinciding with periods of rapid growth and increased sports participation during adolescence. The management patterns observed in this primary care cohort are particularly instructive for rehabilitation professionals. Advice alone constituted the most common intervention at 55.1% of cases, followed by physiotherapy referral at 28.2%, analgesic prescription at 10.4%, and orthopedic referral at 8.9%. These findings highlight that the majority of patients with patellofemoral pain are managed conservatively in primary care, with only a minority receiving specialized rehabilitation services. This pattern suggests potential underutilization of evidence-based exercise interventions that have demonstrated efficacy in controlled trials. Now let's turn to military population incidents. Military populations represent a unique cohort for studying patellofemoral pain due to standardized physical demands, comprehensive medical surveillance, and detailed injury tracking systems. A systematic review with meta-analysis by Rocha and colleagues synthesized data from military studies and reported a pooled incidence of 7.61% for patellofemoral pain syndrome. This substantially higher rate compared to civilian primary care reflects the demanding physical requirements of military training, including running, marching with loads, and repetitive lower extremity activities. The military context also provides insight into risk factors that may generalize to civilian athletic populations engaging in similar high-volume, high-intensity activities. The meta-analysis identified knee extensor weakness as a significant risk factor for developing patellofemoral pain in military recruits, with weaker quadriceps strength at baseline predicting subsequent injury. This finding has important implications for pre-participation screening and preventive strengthening programs in both military and athletic settings. Additionally, shorter activity restrictions following initial injury were associated with better long-term outcomes, challenging traditional approaches that emphasize prolonged rest. Large-scale epidemiological studies of recreational athletes provide population-level data that complement clinical cohort studies. Maringer and colleagues conducted a cross-sectional analysis of 60,997 distance runners entering the Two Oceans Marathon races between 2012 and 2015, identifying 362 participants with a history of patellofemoral pain in the preceding 12 months. This study revealed novel associations between patellofemoral pain and systemic health conditions that expand our understanding of risk beyond traditional biomechanical factors. Independent risk factors for patellofemoral pain in this running population included a composite chronic disease score, with a prevalence ratio of 2.68 for every 2 additional chronic conditions, and history of allergies, with a prevalence ratio of 2.33. These findings suggest that systemic inflammatory processes or immune dysregulation may contribute to patellofemoral pain pathophysiology, representing an important conceptual expansion beyond purely mechanical explanations. The association with multiple chronic diseases has practical implications for clinical assessment, as runners presenting with patellofemoral pain may warrant screening for undiagnosed systemic conditions. Now let's discuss the pathophysiological mechanisms underlying patellofemoral pain. The pathophysiology has evolved from early models focused exclusively on patellar malalignment to contemporary frameworks incorporating tissue homeostasis, neuroplasticity, and psychosocial factors. Current understanding recognizes that patellofemoral pain likely represents a heterogeneous condition with multiple potential contributors, and that the relative importance of different mechanisms varies among individuals. This heterogeneity has implications for both clinical assessment and treatment selection. At the tissue level, patellofemoral pain is conceptualized as resulting from supraphysiological loading of pain-sensitive structures within and around the patellofemoral joint. The subchondral bone, synovium, infrapatellar fat pad, and lateral retinaculum contain nociceptive fibers that can become sensitized with repetitive mechanical stress. Importantly, articular cartilage itself is neural and cannot directly generate pain signals, though cartilage degradation may alter joint mechanics and increase stress on adjacent innervated tissues. The homeostatic model proposes that patellofemoral pain develops when cumulative joint loading exceeds tissue capacity for adaptation and repair. This imbalance may result from acute increases in activity, insufficient recovery between loading bouts, or impaired tissue properties. Supporting this concept, studies have demonstrated elevated markers of bone metabolism and subchondral bone edema on magnetic resonance imaging in individuals with patellofemoral pain, suggesting ongoing tissue remodeling in response to mechanical stress. Neuromuscular deficits represent modifiable contributors to patellofemoral pain that have received extensive research attention. Weakness of the hip abductors, external rotators, and knee extensors has been consistently associated with patellofemoral pain across multiple populations. These strength deficits may contribute to altered lower extremity kinematics during functional activities, including increased hip adduction and internal rotation, knee valgus, and lateral patellar tracking. The resulting maldistribution of contact pressures across the patellofemoral joint may elevate stress on specific regions and contribute to pain. Young and colleagues examined the consequences of patellofemoral pain on adjacent joint injury risk using military health system data. In a cohort of 92,319 individuals diagnosed with patellofemoral pain, 46.6% subsequently sought care for an adjacent joint injury within 2 years. Lumbar spine injuries occurred in 21.2%, ankle-foot injuries in 11.0%, and hip injuries in 3.1%. Here's what's particularly noteworthy about these findings. Receipt of therapeutic exercise for the initial patellofemoral pain reduced the risk of subsequent lumbar injury with a hazard ratio of 0.78, hip injury with a hazard ratio of 0.93, and ankle-foot injury with a hazard ratio of 0.86. These findings suggest that patellofemoral pain may represent a sentinel event indicating broader kinetic chain dysfunction, and that targeted rehabilitation may have protective effects extending beyond the index joint. Now let's examine sex differences in patellofemoral pain in greater detail. Female sex represents one of the most consistently identified risk factors for patellofemoral pain, with women demonstrating 1.3 to 2.2 times higher incidence compared to men across various populations. Understanding the mechanisms underlying this sex disparity is essential for developing targeted prevention and treatment strategies. Recent research has examined anatomical, biomechanical, hormonal, and loading-related factors that may contribute to differential risk. Willie and colleagues investigated sex differences in patellofemoral joint stress during load carriage, a common military and recreational activity. 20 males and 20 females walked on an instrumented treadmill with varying loads of 0 kilograms, 20.4 kilograms, and 34 kilograms, while patellofemoral joint stress was estimated using inverse dynamics musculoskeletal modeling. After controlling for body mass, height, and quadriceps strength, females demonstrated significantly greater increases in peak, impulse per step, and cumulative patellofemoral joint stress with increasing load compared to males. These findings indicate that anthropometric differences and strength alone do not explain the elevated joint stress observed in women during load carriage activities. The clinical implications of these findings are substantial. Female military recruits and athletes may require modified training progressions that allow for gradual adaptation to loaded activities. Specifically, slower progressions in either load magnitude or training distance may reduce cumulative patellofemoral stress and mitigate injury risk. These principles extend to civilian contexts where women engage in hiking, backpacking, or occupational activities involving load carriage. Barch and colleagues provided a comprehensive review of biomechanical and biological factors contributing to sexual dimorphism in anterior knee pain. Women demonstrate, on average, smaller patellar dimensions, higher patellofemoral cartilage stress, disadvantageous trochlear morphology, differences in ligament and muscle composition, and unfavorable neuromuscular control patterns compared to men. Kinetic and kinematic analyses have revealed distinctly different risk factor profiles between sexes, with women showing greater dynamic knee valgus, hip adduction, and tibial rotation during functional tasks. Hormonal influences may also contribute to sex differences in patellofemoral pain risk. Estrogen affects ligamentous laxity, potentially influencing midfoot loading patterns and lower extremity neuromuscular control. Fluctuations in estrogen across the menstrual cycle may create periods of increased vulnerability, though research in this area remains limited. Testosterone's positive effects on muscle mass and strength may provide relative protection for males, though the clinical significance of these hormonal differences requires further investigation. Sex differences in knee injury patterns emerge during childhood and adolescence, with important implications for youth sports participation. Edison and colleagues reviewed sex and gender differences in pediatric knee injuries, noting that female athletes demonstrate elevated vulnerability to patellofemoral pain and anterior cruciate ligament injury compared to males. Anatomical differences, hormonal influences during puberty, and distinct neuromuscular development patterns all contribute to these disparities. Importantly, biological sex differences alone cannot fully explain worldwide disparities in musculoskeletal health outcomes. Social, cultural, and societal attitudes toward gender and girls' participation in sports may result in reduced access to training for both injury prevention and performance optimization. Addressing these disparities requires attention to both biological factors and the broader context in which young athletes develop. More nuanced approaches examining the complex interplay among biological, physiological, and social influences are needed to inform best practices for intervention and injury prevention in youth populations. Let's now examine sport-specific and activity-related risk factors. Certain sports impose unique demands on the patellofemoral joint that elevate injury risk. Steinberg and colleagues examined patellofemoral pain in 274 young female gymnasts across rhythmic, acrobatic, and artistic disciplines. The overall prevalence of patellofemoral pain was 21.5%, with artistic gymnasts demonstrating significantly higher rates at 33.3% compared to acrobatic gymnasts at 11.7%. Logistic regression analyses identified decreased tibial bone density, increased ankle plantar flexion range of motion in the E-endpoint position, and reduced knee extensor and hip abductor strength as factors significantly associated with patellofemoral pain in this population. The findings from gymnast populations highlight the importance of screening for modifiable risk factors from a young age. Training programs should incorporate targeted strengthening of the knee extensors and hip abductors while monitoring bone health, particularly in athletes with high training volumes. The interaction between training hours and patellofemoral pain differed by discipline, suggesting that sport-specific loading patterns influence injury risk beyond simple dose-response relationships. Recent epidemiological research has also identified associations between patellofemoral pain and systemic health conditions that challenge purely biomechanical explanatory models. The finding that chronic disease burden and allergic conditions independently predict patellofemoral pain in distance runners suggests involvement of inflammatory or immune-mediated processes. These associations may reflect shared underlying mechanisms, such as systemic inflammation affecting musculoskeletal tissues, or may indicate that individuals with chronic conditions have altered tissue properties or healing capacity. Similarly, the cycling population demonstrates elevated patellofemoral pain risk among those with multiple chronic diseases. Dutoit and colleagues analyzed data from nearly 60,000 Cape Town Cycle Tour entrants and found that chronic disease history significantly predicted patellofemoral pain. These consistent findings across different endurance sports populations strengthen the evidence for systemic factors contributing to patellofemoral pain risk and warrant consideration during clinical assessment. The epidemiological and pathophysiological evidence reviewed in this module has direct implications for clinical practice. Risk factor assessment should extend beyond traditional biomechanical evaluation to encompass sex-specific considerations, training history, systemic health status, and psychosocial factors. Female patients, particularly adolescents, warrant screening for neuromuscular deficits and may benefit from modified training progressions. Athletes in high-risk sports such as gymnastics and dance should receive proactive screening and targeted prevention programs. The identification of modifiable risk factors provides targets for intervention. Knee extensor and hip abductor weakness are consistently associated with patellofemoral pain and are amenable to exercise-based interventions. Evidence that therapeutic exercise reduces not only patellofemoral pain, but also subsequent adjacent joint injuries supports comprehensive rehabilitation approaches addressing the entire kinetic chain. Clinicians should communicate these concepts to patients, emphasizing the potential for meaningful improvement through targeted rehabilitation. Recognition that patellofemoral pain likely represents a heterogeneous condition with variable pathophysiology among individuals argues against uniform treatment protocols. Instead, clinical reasoning should incorporate assessment findings to identify predominant contributors for each patient and guide treatment selection accordingly. This individualized approach aligns with contemporary best practice recommendations in the biopsychosocial model of pain management that will be explored in subsequent modules. Now let's move into Module 2 on clinical evaluation and differential diagnosis. The clinical evaluation of patellofemoral pain presents unique challenges given the absence of a definitive diagnostic gold standard. Unlike conditions diagnosed through imaging or laboratory findings, patellofemoral pain remains a clinical diagnosis based on symptom presentation, physical examination findings, and exclusion of other pathology. This diagnostic reality places considerable responsibility on the clinician to conduct a thorough, systematic evaluation that captures the multidimensional nature of the condition while ruling out alternative diagnoses that may require different management approaches. Recent best practice guidelines have synthesized decades of research into practical clinical frameworks that balance diagnostic accuracy with examination efficiency. Neal and colleagues developed comprehensive best practice recommendations based on synthesis of 65 randomized controlled trials, patient perspectives, and expert clinical reasoning. These guidelines emphasize that effective clinical evaluation extends beyond traditional orthopedic examination to encompass functional assessment, psychosocial screening, and patient-reported outcome measurement. This module presents an evidence-based approach to clinical evaluation that aligns with current best practice while addressing common diagnostic pitfalls. The diagnosis of patellofemoral pain rests on identification of characteristic symptom patterns combined with physical examination findings. The cardinal feature is diffuse anterior knee pain that is exacerbated by activities that load the patellofemoral joint under flexion. Patients typically report pain with prolonged sitting, which is the classic theater sign, stair negotiation, particularly descent, squatting, running, and kneeling. The insidious onset without specific traumatic mechanism distinguishes patellofemoral pain from acute injuries such as patellar dislocation or ligamentous injury. Pain localization in patellofemoral pain is characteristically diffuse and peripatellar, with patients often circling the entire anterior knee when asked to identify the painful area. This diffuse presentation contrasts with the focal tenderness patterns seen in patellar tendinopathy at the inferior pole, prepatellar bursitis at the anterior patella, or medial plica syndrome at the medial parapatellar region. Bilateral involvement is common, occurring in approximately 50% of cases, and should raise suspicion for patellofemoral pain rather than unilateral structural pathology. The 2024 Best Practice Guide provides a structured diagnostic framework that has achieved broad consensus among researchers and clinicians. The essential diagnostic criteria include peripatellar or retropatellar pain, reproduction of symptoms with at least one activity that loads the patellofemoral joint such as squatting, stair ambulation, prolonged sitting, running, or kneeling, and exclusion of other conditions that may present with anterior knee pain. These criteria emphasize that patellofemoral pain is fundamentally a loading-related condition, and symptom reproduction with provocative activities is essential for diagnosis. The physical examination should systematically assess patellar mobility, crepitus, effusion, and pain provocation. Patellar compression and tilt tests evaluate mechanical factors, though their diagnostic utility is limited by moderate sensitivity and specificity. Crepitus during active knee motion is common but nonspecific, as it occurs frequently in asymptomatic individuals. The absence of significant effusion helps distinguish patellofemoral pain from intra-articular pathology such as meniscal tears or osteoarthritis with synovitis. The physical examination begins with observation of lower extremity alignment, muscle bulk, and gait pattern. Static alignment assessment includes evaluation of foot posture, tibial torsion, femoral anteversion, and overall limb alignment in the frontal plane. While historically emphasized, static alignment measures have shown limited correlation with patellofemoral pain and should not be overweighted in clinical decision-making. More valuable is observation of dynamic alignment during functional tasks, which captures the neuromuscular control deficits that contribute to symptom generation. Quadriceps muscle bulk should be assessed visually and through circumferential measurement, as atrophy indicates chronic disuse or inhibition that requires targeted rehabilitation. The vastus medialis obliquus has received particular attention historically, though current evidence suggests that general quadriceps strengthening is more important than selective vastus medialis training. Hip musculature should also be inspected, as gluteal atrophy may indicate proximal weakness contributing to aberrant lower extremity mechanics. Systematic palpation of anterior knee structures assists in localizing pathology and differentiating patellofemoral pain from other conditions. The patellar facets are assessed with the knee extended and the quadriceps relaxed, allowing the examiner to displace the patella medially and laterally to access the articular surfaces. Tenderness of the patellar facets is consistent with patellofemoral pain but lacks specificity. The patellar tendon, quadriceps tendon, medial and lateral retinacula, and pes anserin bursa should be palpated to identify alternative or concurrent pathology. Patellar mobility testing evaluates the passive excursion of the patella in medial, lateral, superior, and inferior directions. Hypomobility, particularly in the medial direction, may indicate lateral retinacular tightness, while hypermobility suggests ligamentous laxity or prior patellar instability. The patellar tilt test assesses the ability to elevate the lateral patellar border with inability to achieve neutral or beyond, suggesting lateral retinacular tightness. These findings inform treatment selection, particularly regarding soft tissue interventions and taping strategies. Provocative tests aim to reproduce the patient's symptoms through mechanical loading of the patellofemoral joint. The patellar compression test applies direct posterior force to the patella with the knee extended, assessing for pain reproduction. The patellar grind test, also known as Clark's test, combines compression with quadriceps contraction, theoretically increasing patellofemoral contact pressure. While widely used, these tests demonstrate only moderate diagnostic accuracy, and a negative test does not exclude patellofemoral pain. Functional provocative tests often provide more clinically relevant information than isolated joint tests. Single-leg squat assessment reveals both symptom reproduction and movement quality, including dynamic knee valgus, hip drop, and trunk lean that indicate neuromuscular control deficits. Step-down testing similarly challenges patellofemoral loading while permitting observation of lower extremity alignment. Pain reproduction during these functional tasks, combined with observable movement dysfunction, provides diagnostic information and identifies rehabilitation targets simultaneously. Comprehensive strength assessment of the hip and knee musculature is essential given the strong associations between muscle weakness and patellofemoral pain. Manual muscle testing provides screening information, though instrumented dynamometry offers more precise and reliable measurement when available. Key muscle groups for assessment in patellofemoral pain include the knee extensors, hip abductors, hip external rotators, and hip extensors. Systematic review evidence confirms that individuals with patellofemoral pain demonstrate deficits in hip abductor and external rotator strength compared to pain-free controls, supporting routine assessment of these muscle groups. The hamstring musculature warrants specific attention in patellofemoral pain evaluation. Lopes and colleagues conducted a systematic review examining hamstring strength, flexibility, and morphology in individuals with gradual onset knee disorders. Their findings revealed that hamstring characteristics contribute to knee function beyond the commonly assessed quadriceps, supporting comprehensive posterior thigh assessment. Both strength and flexibility of the hamstring should be evaluated, as either deficiency may alter knee mechanics and contribute to patellofemoral loading abnormalities. Flexibility assessment should include the quadriceps, hamstrings, iliotibial band, and gastrocnemius soleus complex. The Ober test evaluates iliotibial band and tensor fasciae latae flexibility, with tightness potentially contributing to lateral patellar tracking forces. Quadriceps flexibility, assessed through prone knee flexion using the Ely test or standing heel to buttock distance, identifies rectus femoris tightness that may increase patellofemoral contact pressure. These flexibility findings guide stretching interventions within the comprehensive treatment plan. Now let's discuss psychosocial assessment in patellofemoral pain, which is critically important. Contemporary understanding of patellofemoral pain recognizes the significant contribution of psychosocial factors to pain experience, disability, and treatment outcomes. The clinical evaluation should therefore extend beyond physical examination to assess psychological constructs that may perpetuate symptoms or impede recovery. This biopsychosocial approach aligns with best practice guidelines and reflects the paradigm shift from purely biomechanical models toward more comprehensive conceptualization of patellofemoral pain. Fear of movement, known as kinesiophobia, and fear avoidance beliefs represent potentially modifiable psychological factors that influence function and recovery in patellofemoral pain. Hart and colleagues conducted a systematic review examining knee confidence, fear of movement, and psychological readiness in individuals with knee conditions. Their meta-analysis demonstrated that elevated fear avoidance beliefs were associated with greater pain intensity, reduced function, and lower return to sport rates. These findings support routine screening for psychological factors as part of comprehensive patellofemoral pain evaluation. Clinical assessment of fear avoidance can be accomplished through standardized questionnaires or directed clinical interview. The Tampa Scale of Kinesiophobia and Fear Avoidance Beliefs questionnaire are validated instruments commonly used in research and clinical practice. Patients with elevated kinesiophobia may require specific intervention addressing these beliefs before physical rehabilitation can achieve optimal outcomes. Identification of these factors early in the evaluation process allows for appropriate treatment planning and prognostic counseling. Emerging evidence highlights the association between patellofemoral pain and broader mental health indicators. Joffrey and Bilo examined mental health status in individuals with patellofemoral pain compared to those with other knee conditions and healthy controls. Their findings revealed that individuals with patellofemoral pain demonstrated lower physical and mental health component scores on standardized health surveys compared to comparison groups. These associations may reflect bidirectional relationships, wherein chronic pain negatively impacts mental health while psychological distress amplifies pain perception and disability. The clinical implications of these findings extend beyond recognition to active intervention. Patients presenting with significant psychological distress may benefit from referral to mental health professionals or integration of psychologically informed approaches within physical therapy. Screening questions addressing mood, anxiety, sleep quality, and overall life satisfaction can identify patients who may require additional support. The rehabilitation professional need not provide psychological treatment directly, but should recognize when psychological factors require attention and facilitate appropriate referrals. Accurate diagnosis of patellofemoral pain requires systematic consideration and exclusion of alternative conditions presenting with anterior knee pain. The differential diagnosis spans structural, inflammatory, and referred pain etiologies that may mimic or coexist with patellofemoral pain. A thorough clinical evaluation with attention to distinguishing features enables appropriate diagnosis and treatment selection while identifying conditions requiring referral or advanced imaging. Patellar tendinopathy, also known as jumper's knee, presents with anterior knee pain that localizes specifically to the inferior pole of the patella at the patellar tendon origin. Unlike the diffuse parapatellar pain of patellofemoral pain syndrome, patellar tendinopathy produces focal tenderness that patients can identify with a single finger. Pain is characteristically load-dependent, worsening with jumping, landing, and acceleration activities. Physical examination reveals point tenderness at the inferior patellar pole, often with palpable tendon thickening. The VISAP questionnaire provides validated assessment of patellar tendinopathy severity and has recently been validated for use in patellofemoral pain populations as well. Patellar instability encompasses a spectrum from subtle subluxation to frank dislocation, and patients may present with anterior knee pain as a primary complaint. History of patellar dislocation events, sensation of the patella giving way or slipping, and apprehension with lateral patellar displacement suggest instability rather than primary patellofemoral pain. Physical examination findings include positive patellar apprehension test, increased lateral patellar mobility, and J-sign, which is lateral patellar deviation during terminal knee extension. Patients with suspected instability warrant imaging assessment of trochlear morphology, patellar height, and tibial tuberosity trochlear groove distance to guide management decisions. The infrapatellar fat pad, known as Hoffa's fat pad, is a richly innervated structure that can become impinged between the patella and femoral condyles, producing anterior knee pain. Fat pad impingement typically presents with pain localized inferior and deep to the patellar tendon, distinct from the parapatellar distribution of patellofemoral pain. Symptoms may worsen with prolonged standing and hyperextension activities. Physical examination reveals tenderness with direct palpation of the fat pad and pain reproduction with Hoffa's test, which involves passive hyperextension of the knee with patellar compression. Fat pad pathology may coexist with patellofemoral pain, complicating clinical presentation. Synovial plica are embryological remnants that persist in many knees without causing symptoms but can become irritated and produce medial parapatellar pain. The medial plica is most commonly symptomatic, presenting with localized medial knee pain and occasionally a palpable, tender cord along the medial patellar border. Patients may describe snapping or catching sensations with knee flexion and extension. The plica stutter test and medial plica shelf test assess for symptomatic plica, though diagnostic accuracy is variable. When clinical suspicion is high, magnetic resonance imaging can visualize thickened plica tissue. Anterior knee pain may represent referred symptoms from proximal structures, most notably the hip and lumbar spine. Hip pathology, including femoroacetabular impingement, labral tears, and early osteoarthritis, can refer pain to the anterior thigh and knee region. Lumbar radiculopathy affecting the L3 or L4 nerve roots may present with anterior knee pain as a primary complaint. A systematic evaluation should include hip range of motion assessment, Faber and Fader testing, and screening lumbar examination when clinical presentation suggests potential referred pain contribution. Patient-reported outcome measures provide standardized assessment of symptoms and function that complements physical examination findings. These instruments enable quantification of baseline status, monitoring of treatment response, and comparison to established benchmarks. Selection of appropriate outcome measures should consider psychometric properties, clinical utility, and relevance to the patient population being evaluated. The Kujala Anterior Knee Pain Scale remains widely used for patellofemoral pain assessment, comprising 13 items addressing symptoms and functional limitations. More recently, the Knee Injury and Osteoarthritis Outcome Score Patellofemoral Subscale, known as the KOOSPF, has emerged as a preferred instrument due to superior psychometric properties and sensitivity to change. The KOSF-BF demonstrates strong correlation with the Kujula scale while offering advantages in measurement precision and interpretability. Validation studies have established clinically meaningful thresholds for interpreting patient-reported outcome scores. Kamoro-Moriana and colleagues validated the VISA-P for use in patellofemoral pain populations, demonstrating strong correlation with the KOOSPF at a row of 0.826 and with the Kujula scale at a row of 0.771. These correlations support the interchangeability of these instruments while acknowledging that each captures slightly different aspects of the patient experience. Clinicians should select instruments based on the specific clinical context and maintain consistency within individual patient monitoring. Assessment of physical activity levels provides important context for understanding symptom impact and guiding rehabilitation goals. Kim and colleagues conducted a systematic review and meta-analysis examining physical activity levels in individuals with patellofemoral pain. Their findings revealed significant activity reductions compared to healthy controls, with implications for cardiovascular health, weight management, and psychological well-being. Objective activity monitoring through accelerometry or pedometry offers precise measurement, while questionnaire-based assessment provides practical clinical alternatives. The reduction in physical activity observed in patellofemoral pain populations creates a potential negative spiral wherein decreased activity leads to deconditioning, weight gain, and psychological distress that further exacerbate symptoms. Recognition of this pattern supports early intervention aimed at maintaining appropriate activity levels within symptom tolerance rather than complete rest. Activity modification guidance should balance joint protection with preservation of overall physical function and quality of life. The comprehensive evaluation described in this module generates substantial clinical information that must be synthesized into a coherent diagnostic formulation and treatment plan. Documentation should clearly articulate the diagnostic reasoning, including positive findings supporting the patellofemoral pain diagnosis and negative findings excluding alternative conditions. Physical examination findings, functional limitations, strength and flexibility deficits, and psychosocial factors should be recorded in sufficient detail to enable treatment planning and outcome monitoring. Best practice guidelines recommend that clinical evaluation identify the primary drivers of symptoms for each individual patient. While patellofemoral pain shares common features across patients, the relative contribution of biomechanical, structural, and psychosocial factors varies considerably. Identifying predominant contributors enables targeted intervention rather than generic treatment protocols. A patient with primary hip weakness requires different emphasis than one with elevated kinesiophobia, though both carry the diagnosis of patellofemoral pain. Communication of evaluation findings to patients represents an important opportunity for education and therapeutic alliance building. Explaining the diagnosis in understandable terms, addressing patient concerns, and outlining the treatment rationale establishes the foundation for successful rehabilitation. Patients who understand their condition and the logic behind treatment recommendations demonstrate better adherence and outcomes than those who receive interventions without adequate explanation. Now let's move into Module 3 on biomechanical assessment and movement analysis. Biomechanical assessment forms a cornerstone of patellofemoral pain evaluation, providing insight into the mechanical factors that contribute to abnormal joint loading and symptom generation. While the relationship between biomechanics and patellofemoral pain is complex and not strictly deterministic, identification of movement abnormalities offers valuable targets for intervention. Contemporary biomechanical assessment extends beyond static alignment measures to emphasize dynamic movement analysis that captures the neuromuscular control strategies employed during functional tasks. The patellofemoral joint experiences substantial forces during daily activities, with joint reaction forces reaching 3 to 4 times body weight during stair climbing and up to 7 times body weight during squatting and running. These forces are distributed across the patellofemoral contact area, which varies with knee flexion angle and patellar tracking patterns. Biomechanical abnormalities that alter force magnitude, distribution, or repetition may exceed tissue tolerance thresholds and contribute to pain. Understanding these mechanical principles provides the foundation for assessment strategies that identify modifiable contributors to patellofemoral loading. The kinetic chain concept recognizes that the patellofemoral joint does not function in isolation but rather as one component of an integrated musculoskeletal system extending from the foot through the trunk. Dysfunction at any level of this chain may propagate forces that ultimately manifest as patellofemoral symptoms. This paradigm has shifted clinical focus from isolated knee assessment toward comprehensive evaluation of proximal hip and trunk and distal foot and ankle contributions to lower extremity mechanics. The hip musculature plays a critical role in controlling femoral position during weight-bearing activities. Weakness or delayed activation of the hip abductors and external rotators permits excessive femoral adduction and internal rotation, which translates to functional knee valgus and increased lateral patellofemoral contact pressure. This proximal mechanism has received substantial research attention and represents one of the most consistently identified biomechanical factors in patellofemoral pain populations. Takekuchi and colleagues examined sex differences in pelvis and lower limb kinematics during single-leg squat performance. Their investigation revealed distinct biomechanical profiles between males and females, with women demonstrating greater contributions from hip adduction and internal rotation to overall dynamic knee valgus. These findings have important clinical implications, suggesting that biomechanical assessment and intervention strategies may require sex-specific consideration. The study employed three-dimensional motion analysis to precisely quantify segmental contributions, though similar patterns can be observed through careful clinical observation. Trunk control represents an often overlooked proximal factor influencing lower extremity mechanics. Ipsilateral trunk lean during single-leg activities shifts the center of mass laterally, reducing the external hip adduction moment and potentially compensating for hip abductor weakness. While this strategy may reduce hip muscle demand, it alters the overall kinetic chain loading pattern and may have downstream consequences for patellofemoral mechanics. Assessment should therefore include observation of trunk position during functional tasks alongside lower extremity kinematics. Foot and ankle mechanics influence tibial rotation and subsequently affect patellofemoral joint loading. Excessive or prolonged foot pronation couples with tibial internal rotation through the subtalar joint axis, which may increase rotational stress at the knee. The relationship between foot mechanics and patellofemoral pain has generated considerable research interest, though findings remain somewhat inconsistent, likely reflecting the heterogeneity of the patellofemoral pain population and the complexity of foot-knee kinematic coupling. Munch and colleagues employed dynamic biplane radiography to characterize subtalar and tibiofemoral coupled motion during gait. This sophisticated imaging technique revealed strong associations between subtalar inversion and eversion with tibiofemoral internal and external rotation during the impact and push-off phases of walking. Notably, significant sex differences emerged, with women remaining more inverted at the subtalar joint and more externally rotated at the tibiofemoral joint at mid-stints compared to men. The rate of tibiofemoral motion relative to subtalar motion also differed between sexes during push-off, suggesting distinct coupling patterns that may contribute to the elevated patellofemoral pain incidence observed in women. These findings provide quantitative evidence supporting the clinical practice of assessing foot mechanics as part of comprehensive patellofemoral pain evaluation. While dynamic biplane radiography remains a research tool, the principles can be applied clinically through observation of rear foot motion, assessment of navicular drop, and evaluation of medial longitudinal arch behavior during dynamic tasks. Identification of excessive pronation or abnormal timing of pronation may indicate potential benefit from foot orthoses or targeted intrinsic foot strengthening. Dynamic movement assessment evaluates lower extremity mechanics during functional tasks that replicate the loading conditions associated with symptom provocation. These assessments bridge the gap between laboratory biomechanical analysis and clinical practice, providing observable movement quality information that guides treatment planning. The goal is identification of movement patterns associated with elevated patellofemoral loading that may be modifiable through targeted intervention. Dynamic knee valgus, characterized by the combination of hip adduction, hip internal rotation, and knee abduction during weight bearing, represents the most commonly assessed movement pattern in patellofemoral pain populations. This movement pattern increases the quadriceps angle and lateral patellofemoral contact pressure while placing greater demand on the medial knee structures. Visual observation during single-leg squat, step-down, or landing tasks can identify clinically significant dynamic valgus, though two-dimensional video analysis provides more reliable quantification. Elmelhat and colleagues explored associations between lower limb biomechanical variables and pain, disability, and postural balance in female athletes with patellofemoral pain. Their investigation confirmed that selected biomechanical characteristics correlate with clinical outcomes, supporting the relevance of movement assessment in this population. The study employed comprehensive lower extremity evaluation, including hip and knee kinematics, strength measures, and balance testing, demonstrating the multifactorial nature of biomechanical contributions to patellofemoral pain presentation. Clinical assessment of dynamic knee valgus can be accomplished through several standardized tasks. The single leg squat requires the patient to squat on one leg to approximately 60 degrees of knee flexion while maintaining balance and alignment. Observation focuses on medial knee displacement relative to the foot, hip drop of the contralateral pelvis, and trunk lean. The examiner rates performance as good when the knee tracks over the foot, moderate when the knee moves medially but not past the great toe, or poor when the knee moves medially past the great toe based on visual assessment. While this categorical rating lacks the precision of motion capture systems, it provides clinically useful information for treatment planning. Step-down testing evaluates eccentric control during a task that closely replicates stair descent, one of the most common symptom-provoking activities in patellofemoral pain. The patient stands on a step or box and slowly lowers the contralateral heel toward the floor while maintaining single-leg stance on the test limb. This task challenges hip and knee extensor control while permitting observation of frontal and transverse plane motion. Performance is rated based on quality of movement control, presence of dynamic valgus, and symptom reproduction. Landing assessment is particularly relevant for athletic populations where jumping and landing activities are common. Drop landing from a standardized height permits observation of impact absorption strategies and lower extremity alignment during the loading phase. Stiff landing patterns with limited knee flexion increase patellofemoral joint loading, while excessive dynamic valgus during landing has been associated with both patellofemoral pain and anterior cruciate ligament injury risk. For runners, assessment of running gait provides activity-specific information addressed in detail in subsequent modules. Squat assessment evaluates bilateral lower extremity mechanics under controlled conditions and provides information relevant to exercise prescription. Observation during bodyweight squat includes assessment of squat depth achieved, symmetry of weight distribution, trunk position, and frontal plane knee alignment. Limited squat depth may indicate ankle dorsiflexion restriction, hip flexor tightness, or avoidance behavior related to pain. Asymmetric weight shifting suggests compensation for unilateral symptoms or strength deficits. Patellofemoral joint loading varies with squat depth, with contact area increasing and peak contact stress occurring between 70 and 100 degrees of knee flexion. Deep squatting beyond 90 degrees continues to increase joint reaction force but distributes this force across a larger contact area, resulting in relatively constant contact stress. These biomechanical principles inform exercise modification strategies, though individual symptom response ultimately guides depth recommendations. Many patients tolerate partial squats to 45 to 60 degrees while experiencing symptoms with deeper flexion angles. Identification of movement dysfunction through biomechanical assessment creates opportunities for targeted corrective exercise intervention. The goal of corrective exercise is to improve movement quality by addressing the underlying impairments contributing to abnormal mechanics. This may include strengthening of weak muscle groups, improving flexibility of tight structures, and retraining neuromuscular control patterns through deliberate practice. Motza-Farapor and colleagues conducted a randomized waitlist controlled trial examining the effectiveness of a comprehensive corrective exercise program for males with dynamic knee valgus. The intervention targeted flexibility, strength, and neuromuscular control deficits identified through baseline assessment. Following the corrective exercise program, participants demonstrated significant improvements in lower extremity kinematics during functional tasks, with reduced hip adduction and knee abduction angles. Crucially, strength measures of the hip abductors and external rotators also improved, confirming that the kinematic changes were accompanied by underlying capacity improvements. The findings from this trial support the trainability of movement patterns through targeted exercise intervention. While the study focused on males with dynamic knee valgus rather than specifically on patellofemoral pain, the movement dysfunctions addressed are those commonly observed in patellofemoral pain populations. The comprehensive nature of the intervention, addressing multiple impairments simultaneously, aligns with clinical reasoning that recognizes movement dysfunction as typically multifactorial rather than attributable to a single deficit. Effective corrective exercise programs typically progress through phases that build movement capacity before challenging neuromuscular control. Initial phases emphasize isolated strengthening of identified weak muscle groups, particularly the hip abductors, external rotators, and knee extensors. Flexibility interventions address tissue restrictions that may limit optimal joint positioning, including the hip flexors, iliotibial band, and gastrocnemius soleus complex. These foundational interventions improve the building blocks available for functional movement. Subsequent phases integrate strengthening gains into functional movement patterns through exercises of progressive complexity. Single-leg exercises challenge hip and knee control under conditions more closely resembling daily and athletic activities. External focus cueing, directing attention to movement outcomes rather than body position, has demonstrated superior effectiveness for motor learning compared to internal focus instructions. For example, cueing a patient to keep your knee over your second toe, which is an external focus, typically produces better results than contract your gluteus medius, which is an internal focus. Visual feedback represents a powerful tool for movement retraining. Mirror training allows patients to observe their own movement patterns and make real-time corrections. Video feedback provides opportunity for delayed review and comparison between baseline and follow-up performance. These feedback modalities leverage the visual system to enhance motor learning and may accelerate improvement compared to verbal instruction alone. Integration of feedback strategies into home exercise programs extends the benefits beyond supervised treatment sessions. The biomechanical differences between males and females described earlier in this module have implications for assessment and intervention strategies. Women demonstrate distinct kinematic patterns during functional tasks, including greater hip adduction and internal rotation contributions to dynamic knee valgus. These differences may reflect anatomical factors such as wider pelvic width relative to femur length, hormonal influences on ligamentous laxity, and potentially different neuromuscular activation strategies. The sex-specific differences in subtalar tibiofemoral coupling described by Munch and colleagues suggest that foot-knee mechanical relationships also vary between sexes. Women demonstrated different trajectories of coupled motion during gait, remaining more inverted at the subtalar joint and externally rotated at the tibiofemoral joint compared to men. These coupling differences may influence how foot mechanics interventions such as orthoses affect knee loading in women versus men, though specific research examining sex-specific orthosis effects remains limited. Clinical implications of sex-specific biomechanics include the need for individualized assessment rather than application of normative standards derived predominantly from male populations. Women may require greater emphasis on hip strengthening and neuromuscular control training given their tendency toward greater hip adduction during functional tasks. Foot mechanics assessment and potential orthotic intervention may also warrant particular attention in female patients. However, individual assessment remains paramount as considerable variability exists within each sex and treatment should be guided by individual findings rather than sex-based assumptions alone. Translation of biomechanical principles into clinical practice requires balance between assessment comprehensiveness and practical time constraints. A tiered approach permits efficient screening with deeper evaluation of identified problem areas. Initial observation during functional tasks such as gait, squat, and single-leg stance provides global impressions of movement quality. Specific tests then quantify impairments in areas of concern, such as hip strength testing when dynamic valgus is observed. Documentation of biomechanical findings should capture both the observed movement patterns and the hypothesized contributing factors. For example, noting dynamic knee valgus during single-leg squat associated with hip abductor weakness and contralateral pelvic drop communicates both the movement finding and the clinical reasoning regarding underlying impairments. This documentation approach facilitates treatment planning and enables meaningful reassessment to monitor intervention effectiveness. The relationship between observed biomechanics and patient symptoms should guide clinical interpretation. Movement patterns that reproduce the patient's symptoms hold greater clinical significance than asymptomatic movement variations. Additionally, the magnitude and consistency of movement dysfunction informs prognosis and treatment intensity. Severe, reproducible dynamic valgus with symptom reproduction warrants more intensive correction than mild, inconsistent findings. This symptom-guided interpretation prevents overpathologizing normal movement variation while directing attention to clinically relevant dysfunction. Now let's move into Module 4 on evidence-based conservative management. Conservative management remains the cornerstone of patellofemoral pain treatment, with exercise therapy established as the primary intervention supported by high-quality evidence. The past several years have witnessed substantial advances in our understanding of optimal exercise parameters, the role of adjunctive interventions, and the potential of digital health technologies to extend treatment reach. This module synthesizes current evidence to provide clinicians with practical guidance for developing individualized, multimodal treatment programs that address the multifactorial nature of patellofemoral pain. The treatment approach should be guided by findings from the comprehensive evaluation described in previous modules. Identification of specific impairments including muscle weakness, flexibility deficits, movement dysfunction, and psychosocial factors enables targeted intervention selection. While certain treatment elements apply broadly across patellofemoral pain populations, the relative emphasis and specific exercise selection should reflect individual patient characteristics. This personalized approach aligns with best practice guidelines and optimizes treatment efficiency. Exercise therapy has accumulated the strongest evidence base among all conservative interventions for patellofemoral pain. Multiple systematic reviews and meta-analyses confirm that structured exercise programs reduce pain and improve function compared to wait-and-see approaches or placebo interventions. The therapeutic effects of exercise likely operate through multiple mechanisms including strength gains, improved neuromuscular control, enhanced tissue capacity, and potentially central nervous system adaptations that modulate pain processing. A fundamental question in patellofemoral pain rehabilitation concerns the relative effectiveness of hip-focused versus knee-focused strengthening programs. Hollaby and colleagues conducted a systematic review with meta-analysis comparing these approaches. Their synthesis of randomized controlled trials revealed that combined hip and knee strengthening produced superior outcomes compared to knee strengthening alone. Specifically, programs incorporating hip abductor and external rotator exercises alongside quadriceps strengthening demonstrated greater pain reduction and functional improvement than isolated quadriceps programs. The mechanistic rationale for combined strengthening relates to the kinetic chain contributions to patellofemoral loading discussed in Module 3. Hip weakness permits excessive femoral adduction and internal rotation during weight-bearing, increasing lateral patellofemoral contact pressure. Quadriceps weakness reduces the capacity to control knee flexion during loading and may alter patellar tracking. Addressing both proximal and local deficits provides comprehensive treatment of the mechanical factors contributing to symptoms. Clinically, this evidence supports routine inclusion of hip strengthening within patellofemoral pain rehabilitation programs rather than exclusive focus on the quadriceps. The optimal dosage of therapeutic exercise for patellofemoral pain has been examined through dose-response analyses comparing different training volumes. Almeida and colleagues conducted a systematic review with meta-analyses specifically examining the effect of equalized versus non-equalized resistance training volumes on pain and disability. When exercise volume was equalized between comparison groups, differences in outcome between hip-focused and knee-focused programs diminished, suggesting that total training volume may be as important as specific muscle group targeting. Zhang and colleagues extended this investigation by examining effects of lower limb strengthening on both clinical outcomes and biomechanical characteristics. Their meta-analysis confirmed that strengthening programs improve pain and function while also producing measurable changes in lower limb biomechanics during functional tasks. This dual effect on symptoms and mechanics supports the mechanistic basis for exercise therapy and suggests that biomechanical assessment may provide objective markers of treatment response complementing patient-reported outcomes. The contribution of core stability to lower extremity function has generated interest in trunk-focused interventions for patellofemoral pain. Wang and colleagues synthesized evidence on core training for pain management and functional improvement in patellofemoral pain. Their systematic review and meta-analysis found that core training programs produce significant improvements in pain and function, supporting inclusion of trunk strengthening within comprehensive treatment programs. The effects may operate through improved lumbopelvic control during single-leg activities, reducing compensatory movements that alter lower extremity mechanics. Raju and colleagues directly compared hip abductor with external rotator strengthening versus proprioceptive training in patients with patellofemoral pain syndrome. Their randomized controlled trial demonstrated that hip strengthening produced greater improvements in Kujala anterior knee pain scale scores compared to proprioceptive training, both of which exceeded conventional physical therapy alone. These findings reinforce the importance of addressing hip muscle strength as a primary treatment target, while suggesting that proprioceptive training, though beneficial, may be considered a secondary intervention. While exercise therapy forms the foundation of patellofemoral pain treatment, various adjunctive interventions may enhance outcomes when combined with therapeutic exercise. The critical clinical question is whether these additional modalities provide sufficient incremental benefit to justify their inclusion in treatment programs. Recent systematic reviews have specifically examined the additive effects of adjunct treatments beyond exercise therapy alone. Suto and colleagues conducted a comprehensive systematic review with meta-analysis examining whether adjunct treatments improve pain and function when added to exercise therapy in patellofemoral pain. This investigation specifically assessed the incremental benefit of various modalities rather than their effectiveness in isolation. The review applied rigorous methodology including appraisal of intervention quality, providing clinicians with high-quality evidence to guide treatment decisions. The findings revealed that neuromuscular electrical stimulation demonstrated the most consistent evidence for benefit when added to exercise therapy, with moderate certainty evidence supporting its use. Other modalities, including taping, manual therapy, and various physical agents, showed less consistent or lower certainty evidence for additive benefit. These results suggest that clinicians should prioritize exercise therapy and consider neuromuscular electrical stimulation as the adjunct with strongest support, while other modalities may be selected based on individual patient factors and clinical reasoning. Kinesiology taping has gained widespread popularity for musculoskeletal conditions including patellofemoral pain. 2 recent meta-analyses have examined its effectiveness specifically in this population. Gao and colleagues investigated the efficacy of kinesiology taping combined with exercise therapy. Their synthesis found that the combination produced greater short-term improvements in pain and function compared to exercise therapy alone, though effect sizes were modest and long-term benefits remained unclear. Zhao and colleagues conducted a separate meta-analysis on kinesiology taping for patellofemoral pain. Their findings similarly supported short-term benefits for pain reduction and improved knee function. The mechanism of kinesiology taping effects remains debated, with proposed theories including enhanced proprioceptive feedback, altered muscle activation patterns, and psychological effects related to treatment expectation. Regardless of mechanism, the evidence supports kinesiology taping as a reasonable adjunct when short-term symptom modulation is desired, though it should not replace active exercise interventions. Neuromuscular electrical stimulation applied to the quadriceps has theoretical benefits for patellofemoral pain through enhanced muscle activation and strengthening effects. Abdulhamid and colleagues conducted a systematic review and meta-analysis specifically examining NMES effectiveness on pain, function, and quadriceps strength in patellofemoral pain. Their analysis found moderate quality evidence supporting NMES for improving pain and quadriceps strength when added to standard treatment programs. Zheng and colleagues similarly examined the additive effect of NMEs when combined with exercise therapy. Their meta-analysis confirmed that NMEs plus exercise produced superior outcomes compared to exercise alone, with significant improvements in both pain and function. The consistency of these findings across multiple systematic reviews strengthens the evidence supporting NMEs as an effective adjunct. Clinical application typically involves NMES applied during or separate from therapeutic exercise, with protocols varying in frequency, intensity, and treatment duration. Blood flow restriction training represents an emerging modality that enables strength gains at lower training loads through metabolic stress mechanisms. Zeitlin and colleagues conducted a systematic review with meta-analysis comparing blood flow restriction training to conventional training in individuals with knee pain. Their synthesis included studies on patellofemoral pain among other knee conditions. Results suggested potential benefits of blood flow restriction training, though evidence certainty remained low due to limited study numbers and methodological variability. The theoretical advantage of blood flow restriction training for patellofemoral pain relates to the ability to achieve strengthening effects with reduced joint loading. Traditional high-load resistance training may provoke symptoms in some patients, limiting exercise tolerance and training progression. Blood flow restriction training at 20 to 30% of one repetition maximum can produce strength gains comparable to high-load training while minimizing patellofemoral joint stress. This approach may be particularly valuable for patients who demonstrate pain-limited exercise tolerance with conventional loading parameters. Dry needling targets myofascial trigger points and may influence pain through peripheral and central mechanisms. 2 recent systematic reviews have examined dry needling for patellofemoral pain. Rashnavati and colleagues synthesized evidence on dry needling effectiveness in this population. Their meta-analysis found that dry needling produced significant improvements in pain and function, though the magnitude of effect and durability of benefits varied across studies. Sun and Liu conducted a separate meta-analysis on therapeutic effects of dry needling for patellofemoral pain. Their findings similarly supported effectiveness for pain reduction and functional improvement. Common targets for dry needling in patellofemoral pain include the vastus medialis, vastus lateralis, rectus femoris, tensor fascia latae, and gluteal muscles. As with other adjunctive interventions, dry needling should complement rather than replace exercise therapy with the goal of reducing pain barriers to active rehabilitation participation. Recognition of kinetic chain contributions to patellofemoral pain has prompted investigation of proximal manual therapy interventions. Lin and colleagues examined the effect of lumbopelvic manipulation for pain reduction in patellofemoral pain syndrome through systematic review and meta-analysis of randomized controlled trials. Their findings suggested that lumbopelvic manipulation may provide short-term pain relief when added to standard care, though the clinical significance and optimal patient selection criteria require further clarification. The mechanism by which lumbopelvic manipulation might influence knee symptoms likely involves neurophysiological effects on pain processing rather than direct mechanical changes at the patellofemoral joint. Regional interdependence models propose that treatment of one body region can influence symptoms in anatomically related regions through shared innervation and central nervous system connections. Clinicians considering lumbopelvic manual therapy for patellofemoral pain should recognize the theoretical basis while acknowledging that exercise therapy remains the primary evidence-based intervention. Digital health technologies have emerged as promising tools for extending the reach and enhancing the effectiveness of patellofemoral pain treatment. These technologies range from simple exercise video platforms to sophisticated mobile applications incorporating behavior change principles and real-time feedback. The COVID-19 pandemic accelerated adoption of remote care delivery, generating new evidence on digital therapeutic effectiveness and patient acceptance. Lee and colleagues conducted a randomized controlled trial examining a mobile multidisciplinary digital therapeutics application for patellofemoral pain. The application combines structured exercise programming with cognitive behavioral therapy principles, representing an integrated biopsychosocial approach delivered through a smartphone platform. Results demonstrated significant pain reduction in participants using the digital therapeutic compared to control conditions, supporting feasibility and efficacy of app-based treatment delivery. The integration of psychological components within the digital therapeutic platform reflects contemporary understanding of patellofemoral pain as a condition influenced by both physical and psychological factors. Cognitive behavioral principles address fear avoidance beliefs, pain catastrophizing, and self-efficacy that may perpetuate symptoms independent of structural or biomechanical factors. Delivery through a mobile application enables consistent reinforcement of these concepts between clinical encounters, potentially enhancing treatment effects compared to exercise instruction alone. Menek and Dancik compared supervised, web-based, and self-guided exercise interventions for women with patellofemoral pain syndrome. This pragmatic comparison examined real-world delivery formats that differ in resource intensity and accessibility. Supervised exercise produced the greatest improvements, consistent with the value of direct clinician guidance. However, web-based and self-guided interventions also produced meaningful improvements compared to baseline, suggesting that technology-assisted approaches can deliver benefit even without direct supervision. Ferner and colleagues examined a digital therapeutic compared to standard care in patients with anterior knee pain. Their randomized controlled trial found that the digital therapeutic produced superior outcomes compared to standard care, with significant improvements in pain and function. These findings support digital therapeutics as a viable treatment delivery mechanism that may offer advantages including increased accessibility, consistent exercise instruction, and progress monitoring capabilities. The clinical implications of digital therapeutic evidence include expanded treatment options for patients with limited access to specialized rehabilitation services. Rural populations, individuals with transportation barriers, and those with scheduling constraints may benefit from technology-assisted care that supplements or partially substitutes for in-person visits. However, digital therapeutics should not entirely replace clinical evaluation and supervised treatment, particularly for complex presentations requiring individualized assessment and intervention modification. Translation of the evidence reviewed in this module into clinical practice requires synthesis of multiple treatment elements into coherent, individualized programs. The foundational principle is that exercise therapy targeting hip and knee strength should form the core of all treatment programs. Selection of adjunctive interventions should be guided by individual patient characteristics, treatment goals, and available resources. Digital therapeutics may extend treatment reach and enhance adherence but should complement rather than replace clinical care. Treatment progression should follow principles of gradual loading and symptom monitoring. Initial phases emphasize pain management and establishment of exercise tolerance, potentially incorporating adjuncts such as taping or NMEs to facilitate active participation. Progressive strengthening phases increase exercise intensity as tolerance permits, with the goal of building sufficient capacity to meet functional demands. Final phases address sport-specific or activity-specific requirements, integrating strengthening gains into functional movement patterns. Patient education represents a critical but often underemphasized treatment component. Explaining the rationale for exercise therapy, setting realistic expectations for recovery timelines, and addressing psychosocial factors that may impede progress contribute to treatment success. Patients who understand their condition and the logic behind treatment recommendations demonstrate better adherence and outcomes than those receiving interventions without adequate context. Now let's move into Module 5 on sport-specific and sex-specific considerations. While the foundational principles of patellofemoral pain management apply broadly, certain populations present unique considerations that warrant specialized treatment approaches. Runners require attention to gait mechanics and training load management. Adolescents face developmental factors and psychosocial challenges distinct from adult populations. Female athletes demonstrate biomechanical and physiological characteristics that influence injury risk and treatment response. This module addresses these population-specific considerations to enable clinicians to tailor evidence-based interventions to individual patient needs. The concept of individualized treatment extends beyond selecting appropriate exercises to encompass the manner of treatment delivery, communication strategies, and goal-setting processes. An adolescent female dancer presents fundamentally different challenges than a middle-aged recreational runner, despite sharing the diagnosis of patellofemoral pain. Recognition of these differences and adaptation of treatment approach accordingly represents sophisticated clinical practice that optimizes outcomes across diverse patient populations. Running represents one of the most common activities associated with patellofemoral pain, with the repetitive loading of thousands of strides per session creating cumulative stress on the patellofemoral joint. Runners with patellofemoral pain require evaluation of running mechanics in addition to the standard clinical assessment, as gait-specific factors may contribute to symptoms and represent targets for intervention. The emergence of gait retraining as an evidence-based treatment modality has expanded the therapeutic options available for this population. Anderson and Crossley conducted a systematic review with meta-analysis examining gait retraining interventions for patellofemoral pain. Their synthesis included studies employing various gait modification strategies, with cadence manipulation emerging as the most commonly studied approach. The meta-analysis found that gait retraining produced significant improvements in pain and function, supporting its inclusion as a treatment component for runners with patellofemoral pain. Importantly, the benefits of gait retraining appeared to complement rather than replace traditional strengthening interventions. The mechanistic basis for gait retraining effects relates to modification of patellofemoral joint loading during running. Increasing step rate, or cadence, by 5 to 10% reduces stride length and consequently decreases peak knee flexion angle at midstance. This kinematic change reduces the patellofemoral joint reaction force per step while also reducing loading rate. The cumulative effect across a running session is substantial reduction in patellofemoral stress exposure, potentially allowing symptomatic tissues to recover while maintaining running participation. D'Souza Jr. and colleagues conducted a randomized controlled trial comparing gait retraining plus strengthening to strengthening alone in runners with patellofemoral pain. The gait retraining protocol targeted a 7.5 to 10% increase in step rate, achieved through real-time auditory feedback using a metronome application. Following the intervention period, the combined gait retraining and strengthening group demonstrated greater improvements in pain and function compared to strengthening alone, providing direct evidence for the additive benefit of gait modification. Clinical implementation of cadence-based gait retraining begins with baseline assessment of preferred step rate, typically measured during treadmill running at self-selected pace. Target cadence is calculated as 107.5 to 110% of baseline, and patients are instructed to match foot strike to metronome beats during training runs. Initial sessions may feel awkward as patients adapt to the novel movement pattern, and clinicians should prepare patients for this adjustment period. Progression involves gradual weaning from external cueing as the new pattern becomes automatic, typically over 4 to 6 weeks of consistent practice. While cadence increase represents the most studied gait retraining approach, alternative strategies may benefit specific patient presentations. Transition toward forefoot or midfoot striking patterns reduces patellofemoral loading compared to rearfoot striking, though this modification requires careful progression to avoid Achilles tendon overload. Trunk position modification, specifically reducing forward lean, may benefit runners who demonstrate excessive hip flexion during stance. Selection among gait modification strategies should be guided by individual biomechanical assessment findings. Visual feedback during gait retraining can accelerate learning and enhance retention of new movement patterns. Mirror running, video feedback, and real-time kinematic displays have all demonstrated utility in gait modification programs. The choice of feedback modality may depend on available technology and patient learning style preferences. Regardless of method, The goal is development of automatic motor patterns that persist without conscious attention during recreational or competitive running. Adolescent patients with patellofemoral pain present unique challenges related to developmental stage, psychosocial factors, and treatment adherence. The peak incidence of patellofemoral pain at age 13 years coincides with periods of rapid growth, sports specialization, and identity formation that influence both injury risk and treatment response. Effective management of adolescent patellofemoral pain requires attention to these developmental considerations alongside the physical rehabilitation components. The adolescent growth spurt creates transient periods of relative muscle weakness as bone growth outpaces muscle adaptation. This temporary imbalance may increase patellofemoral joint stress during a developmental window when sports participation often intensifies. Additionally, growth-related changes in limb proportions alter lower extremity mechanics, potentially requiring motor control adaptations that develop gradually. Clinicians should recognize that some degree of biomechanical awkwardness during rapid growth phases is normal and distinguish this from pathological movement dysfunction requiring intervention. Gaudet and colleagues examined sex differences in lower extremity kinetics, and muscle activity during single-leg landings in adolescents. Their investigation revealed that adolescent females demonstrated distinct biomechanical patterns compared to males, including differences in knee and hip kinematics that may contribute to their elevated patellofemoral pain risk. These findings suggest that sex-specific considerations are relevant even in younger populations and may inform early intervention strategies aimed at modifying injury risk profiles. Psychological factors play a particularly important role in adolescent patellofemoral pain, with fear avoidance beliefs, pain catastrophizing, and self-efficacy influencing outcomes. Selhorst and colleagues conducted a randomized controlled trial examining the effect of psychologically informed education added to physical therapy for adolescents with patellofemoral pain. The intervention consisted of a video-based education series addressing pain neuroscience, fear avoidance, and activity modification strategies, delivered as an adjunct to standard physical therapy care. Results demonstrated that adolescents receiving the psychologically informed education showed greater improvements in function, pain, and psychological measures compared to those receiving standard education videos. Specifically, the intervention group demonstrated significant reductions in fear avoidance beliefs, kinesiophobia, and pain catastrophizing. These findings support systematic integration of psychological education within adolescent patellofemoral pain treatment and suggest that addressing cognitive and emotional factors may be as important as physical rehabilitation for optimizing outcomes in this population. Clinical application of these findings involves incorporating pain education and psychological support within routine treatment, explaining that hurt does not always equal harm, teaching appropriate activity modification rather than complete rest, and building confidence through graded exposure to feared activities represent practical strategies. Involvement of parents or guardians in education sessions may enhance reinforcement of key messages and support home program adherence. Dancers and athletic athletes face unique demands that distinguish their patellofemoral pain presentations from other athletic populations. The combination of extreme flexibility requirements, repetitive jumping and landing, prolonged positions of knee flexion, and aesthetic performance pressures creates a distinct risk profile. Effective treatment must account for the specific movement vocabulary and performance demands of dance while addressing underlying impairments contributing to symptoms. Steinberg and colleagues examined risk factors for patellofemoral pain persistence and development in pubertal dancers through a longitudinal cohort study. Their investigation followed dancers over 12 months, comparing those who developed patellofemoral pain, those whose symptoms persisted, those who recovered, and those who remained healthy. Dancers who developed or maintained patellofemoral pain demonstrated reduced tibial bone strength, altered tendon structure characterized by increased echotype 3 tissue, increased joint range of motion, and reduced muscle strength of the knee flexors, knee extensors, and hip adductors compared to healthy dancers or those who recovered. These findings highlight the multifactorial nature of patellofemoral pain in dancers and identify several potentially modifiable risk factors. The association between reduced muscle strength and symptom development supports prioritization of strengthening interventions within dancer rehabilitation programs. The finding of altered tendon structure in affected dancers suggests that tendon health monitoring may have predictive value, though clinical assessment of tendon properties remains challenging outside of imaging or specialized testing environments. Rehabilitation for dancers must ultimately prepare them to return to the specific demands of their art form. This requires understanding of dance terminology, movement vocabulary, and performance requirements that differ substantially from conventional athletic activities. Plie, releve, grand battement, and other fundamental dance movements impose distinct loading patterns on the patellofemoral joint that should inform exercise selection and progression. Clinicians unfamiliar with dance may benefit from observing classes or collaborating with dance medicine specialists to optimize treatment specificity. The turnout position fundamental to classical ballet places particular demands on hip external rotation and may compensate for limitations through excessive tibial or foot rotation. Assessment of turnout mechanics and identification of compensatory strategies informs treatment planning. Strengthening in positions of turnout, gradual restoration of dance-specific movements, and eventual return to full-class participation represent the rehabilitation continuum. Communication with dance instructors regarding activity modification and return to dance progression facilitates coordinated care. Military personnel and tactical athletes face occupational demands including load carriage, obstacle negotiation, and sustained physical activity under challenging conditions. These populations demonstrate elevated patellofemoral pain incidence compared to civilian athletes, reflecting the cumulative stress of training and operational requirements. Treatment approaches must account for the occupational context and return-to-duty imperatives that may differ from recreational athletic populations. Pontillo and colleagues conducted a systematic review examining patellofemoral pain in the military population. Their synthesis identified load carriage as a significant contributor to patellofemoral symptoms, with the combination of external load and repetitive locomotion creating substantial joint stress. The review emphasized that military-specific rehabilitation must address load carriage tolerance as a functional outcome, not merely pain reduction during unloaded activities. Progressive load carriage training following symptom resolution prepares service members for return to full-duty requirements. Sex differences in patellofemoral joint stress during load carriage, as documented in Module 1, have particular relevance for military populations where women now serve in all occupational roles. Female service members may require modified training progressions that allow for gradual adaptation to loaded activities. Unit-level awareness of these biomechanical differences can inform training program design that optimizes physical readiness while minimizing injury risk across the force. Military return-to-duty decisions involve considerations beyond symptom resolution, including physical readiness for demanding operational tasks, unit mission requirements, and medical retention standards. Rehabilitation progression should incorporate military-relevant functional testing that simulates occupational demands. Ruck marching at gradually increasing distances and loads, obstacle course completion, and tactical movement assessments provide objective measures of readiness that complement traditional clinical outcome measures. The evidence that therapeutic exercise for patellofemoral pain reduces subsequent adjacent joint injury risk has particular significance for military populations facing sustained physical demands over extended careers. Investment in comprehensive rehabilitation may yield long-term benefits extending beyond the index patellofemoral pain episode to reduce overall musculoskeletal injury burden and preserve force readiness. The sex differences in patellofemoral pain incidence, biomechanics, and presentation described throughout this course have practical implications for treatment planning. Female patients may benefit from greater emphasis on hip strengthening given their tendency toward dynamic valgus patterns. Attention to hormonal influences on tissue properties may inform training periodization around menstrual cycle phases, though evidence for cycle-based programming remains limited. Recognition that women experience greater patellofemoral stress during loaded activities suggests that progression criteria may require sex-specific calibration. Importantly, sex-specific considerations should inform rather than constrain treatment decisions. Substantial individual variability exists within each sex, and treatment should ultimately be guided by individual assessment findings. A female athlete with excellent hip strength and no dynamic valgus requires different emphasis than one with marked proximal weakness, despite sharing demographic characteristics. The goal is integration of population-level evidence with individual clinical findings to optimize treatment specificity. Now let's move into Module 6 on outcome measurement and return to sport criteria. Systematic outcome measurement serves multiple essential functions in patellofemoral pain management. At the individual patient level, standardized assessment enables objective monitoring of treatment response, identification of patients who are not progressing as expected, and documentation of meaningful clinical improvement. At the practice level, outcome data inform quality improvement initiatives and demonstrate value of services to payers and healthcare systems. Selection of appropriate outcome measures requires understanding of psychometric properties, clinical utility, and relevance to the patient population being served. The outcome measurement framework for patellofemoral pain should capture multiple domains relevant to patient experience and function. Pain intensity provides a fundamental indicator of symptom severity but offers limited insight into functional impact. Patient-reported outcome measures assess the effect of symptoms on daily activities and quality of life. Performance-based measures evaluate physical capacity through standardized functional tasks. Psychological measures capture cognitive and emotional factors that influence recovery. Comprehensive outcome assessment incorporates measures across these domains to provide a complete picture of patient status and treatment response. Patient-reported outcome measures have emerged as essential tools for evaluating treatment effectiveness from the patient perspective. These standardized questionnaires capture information that cannot be obtained through physical examination or performance testing, including subjective symptom experience, activity limitations, and participation restrictions. The choice among available instruments should be guided by psychometric properties, clinical feasibility, and alignment with treatment goals. Several patient-reported outcome measures have been validated specifically for anterior knee pain populations. The Kujula Anterior Knee Pain Scale, developed in 1993, remains widely used due to its extensive validation history and familiarity among clinicians and researchers. This 13-item instrument assesses symptoms and functional limitations across activities including walking, running, jumping, squatting, and stair climbing. Scores range from 0 to 100, with higher scores indicating better function. The minimal clinically important difference for the Kujala scale is approximately 10 points, providing a threshold for interpreting meaningful change. The knee injury and osteoarthritis outcome score includes a patellofemoral specific subscale known as the KUS-PF that has demonstrated strong psychometric properties in patellofemoral pain populations. The KUS-PF contains 11 items addressing patellofemoral specific symptoms and functional limitations. Advantages of the KUS-PF include its development using modern psychometric methods, availability in multiple languages, and integration within the broader KUS framework that enables comparison across knee conditions. Figueredo and colleagues conducted a systematic review examining patient-reported outcome measures for patellofemoral pain, analyzing the psychometric properties and clinical utility of available instruments. Their synthesis evaluated reliability, validity, responsiveness, and interpretability across outcome measures commonly used in patellofemoral pain research and clinical practice. The review found that multiple instruments demonstrate acceptable psychometric properties, though measurement precision and sensitivity to change varied across instruments and patient populations. The systematic review highlighted the importance of selecting outcome measures appropriate to the clinical context and patient population. Instruments validated primarily in adult populations may perform differently in adolescents or specific athletic groups. Similarly, measures developed for general anterior knee pain populations may lack sensitivity for detecting change in highly functional athletes whose baseline scores approach ceiling values. Clinicians should consider these factors when selecting outcome measures and interpreting results, recognizing that no single instrument is optimal for all clinical situations. The Victorian Institute of Sport Assessment for Patellar Tendinopathy, known as the VISAP, was originally developed for patellar tendinopathy but has recently been validated for use in patellofemoral pain populations. This cross-validation expands the clinical utility of the VISAP and enables comparison across anterior knee pain conditions. The instrument assesses pain during specific activities and functional tasks, providing information complementary to more general outcome measures. Validation studies have established the VISAP as a reliable and valid measure in patellofemoral pain, with strong correlations to established instruments including the KUS-PF and Kujula scale. The availability of the VISAP for patellofemoral pain assessment provides clinicians with an additional validated option that may be particularly useful in settings where differentiation between patellar tendinopathy and patellofemoral pain is challenging or where patients present with overlapping features of both conditions. Performance-based outcome measures complement patient-reported instruments by providing objective assessment of physical function. These measures evaluate specific aspects of movement capacity under standardized conditions, enabling reliable comparison across time points and between patients. While patient-reported measures capture the subjective experience of function, performance-based tests assess what patients can actually do, which may differ from their perceived capabilities. The single-leg hop for distance represents one of the most commonly used performance measures in lower extremity rehabilitation. Patients perform a single-leg horizontal jump, landing on the same limb, with distance measured from toe at takeoff to heel at landing. Comparison between involved and uninvolved limbs generates a limb symmetry index, with values greater than 90% often considered acceptable for return to sport. The single-leg hop assesses power generation, neuromuscular control, and confidence in the affected limb. Triple hop and crossover hop tests provide additional challenges that assess different aspects of lower extremity function. The triple hop involves 3 consecutive single-leg hops with total distance measured, requiring sustained power output and fatigue resistance. The crossover hop adds a lateral component by requiring patients to hop alternately across a line, challenging frontal plane stability and control. Combined hop test batteries provide more comprehensive assessment than any single test and improve prediction of functional readiness. Time stair tests assess a functional activity commonly affected by patellofemoral pain and relevant to daily living requirements. Patients ascend and descend a standardized flight of stairs as quickly as possible while maintaining safety, with completion time serving as the outcome measure. Stair tests have demonstrated good reliability and validity in patellofemoral pain populations and capture functional limitation that may not be apparent during level walking. The provocative nature of stair activities makes them particularly relevant for documenting treatment response. Isometric and isokinetic strength testing provides quantitative assessment of muscle force production capacity. Quadriceps strength testing is most commonly performed, given the well-established associations between knee extensor weakness and patellofemoral pain. Hip abductor and external rotator strength assessment complements knee testing and evaluates the proximal contributors to lower extremity mechanics. Strength measures expressed as limb symmetry indices or normalized to body weight enable comparison across patients and time points. The selection of performance-based measures should reflect treatment goals and functional demands of the patient population. A recreational walker may require only stair and walking assessments, while a competitive athlete needs comprehensive hop testing and sport-specific functional evaluation. Ceiling effects limit the utility of basic functional tests in highly athletic populations, necessitating more challenging assessments that discriminate among individuals with high baseline function. Return to sport decision-making represents one of the most consequential applications of outcome assessment in athletic populations with patellofemoral pain. Premature return risks symptom recurrence, prolonged disability, and potential progression to chronic pain states. Conversely, unnecessarily delayed return may negatively impact athletic development, team dynamics, and psychological well-being. Evidence-based criteria that balance these competing considerations optimize timing of return to sport decisions. Traditional return to sport criteria have relied heavily on time-based protocols, with athletes cleared to return after a specified number of weeks regardless of individual recovery trajectory. Contemporary approaches instead emphasize criterion-based progression, where advancement depends on achieving specific functional benchmarks rather than simply waiting for time to pass. This individualized approach accounts for the substantial variability in recovery rates among athletes with seemingly similar presentations. Consensus recommendations for return to sport following patellofemoral pain incorporate multiple domains including pain resolution, strength restoration, functional performance, and psychological readiness. Pain during sport-specific activities should be minimal and not worsening over consecutive sessions. Strength symmetry greater than 90% between limbs indicates adequate muscle capacity for athletic demands. Hop test performance greater than 90% of the uninvolved limb demonstrates power and neuromuscular control. Psychological screening confirms confidence and readiness to return without excessive fear or anxiety. While patellofemoral pain is typically managed conservatively, some patients with recurrent patellar instability require surgical interventions such as medial patellofemoral ligament reconstruction. Understanding return to sport outcomes following surgical stabilization informs rehabilitation planning and patient counseling for the subset of patients who may present initially with anterior knee pain symptoms. Pusatiello and colleagues conducted a systematic review examining return to sport outcomes after medial patellofemoral ligament reconstruction. Their analysis revealed important associations between return timing and subsequent symptoms. Return to sport earlier than 9 months following MPFL reconstruction was associated with increased rates of anterior knee pain compared to later return. This finding suggests that even after achieving functional milestones, allowing adequate time for tissue maturation and adaptation may be important for optimizing long-term outcomes. The implications of these findings extend to rehabilitation programming and patient counseling. Athletes undergoing MPFL reconstruction should be prepared for an extended rehabilitation timeline, with return to competitive sport typically occurring at 9 to 12 months postoperatively. Criterion-based progression remains important, but time-based considerations should not be abandoned entirely given the association between early return and adverse outcomes. Communication of these expectations from the outset facilitates psychological adjustment and appropriate goal setting. Psychological readiness represents an increasingly recognized component of return-to-sport decision-making that complements physical assessment. Athletes may demonstrate adequate strength and functional performance while harboring fears, doubts, or anxieties that impede full participation or predispose to re-injury. Assessment of psychological readiness provides information that cannot be obtained through physical testing alone and identifies athletes who may benefit from targeted psychological intervention before returning to competition. Several instruments have been developed to assess psychological readiness for return to sport. The anterior cruciate ligament return to sport after injury scale, known as the ACL-RSE, has been validated for use in various knee conditions beyond ACL injury. This 12-item questionnaire assesses emotions, confidence, and risk appraisal related to returning to sport. Scores range from 0 to 100, with higher scores indicating greater psychological readiness. While originally developed for ACL populations, the ACL-RSI items address concerns relevant to athletes recovering from any knee condition affecting sport participation. Integration of psychological assessment within return-to-sport protocols requires establishing thresholds that distinguish athletes who are psychologically prepared from those who may benefit from additional support. Research suggests that ACL-RSI scores below 56 to 60 points are associated with reduced likelihood of successful return to primary sport level. Athletes with low psychological readiness scores may require graded exposure to sport-specific activities, cognitive behavioral interventions addressing fear and anxiety, or referral to sport psychology specialists before full return is recommended. The return to sport process should be conceptualized as a continuum rather than a single decision point. Progressive exposure to sport-specific demands allows assessment of symptom response under increasingly challenging conditions while building confidence and physical capacity. This graduated approach identifies athletes who experience symptom recurrence at specific loading thresholds, enabling targeted intervention before full return attempts. Return to sport progression typically begins with sport-specific training activities performed at reduced intensity without competition. Running-based sports progress from straight-line running to change-of-direction drills to reactive agility before full practice participation. Jumping and landing sports incorporate progressive plyometric training that builds toward competition intensity demands. Throughout this progression, symptom monitoring guides advancement decisions, with any significant increase in pain triggering reassessment and potential modification. Full clearance for competitive sport participation should occur only after successful completion of sport-specific training at competition intensity without symptom exacerbation. The athlete should demonstrate confidence in performing all required movements and express readiness to compete. Follow-up assessment at regular intervals after return ensures that sport participation is not causing progressive symptom worsening, allowing early intervention if problems emerge. This ongoing monitoring recognizes that return to sport represents a transition rather than an endpoint in the rehabilitation process. Long-term outcome monitoring provides essential information about the durability of treatment effects and natural history of patellofemoral pain. While many patients experience meaningful improvement with appropriate treatment, a substantial proportion continue to report symptoms at extended follow-up. Understanding prognosis enables realistic patient counseling and identifies factors that predict favorable prognosis versus unfavorable outcomes. Systematic reviews examining prognosis of patellofemoral pain have reported that approximately 50 to 60% of patients continue to experience symptoms at one-year follow-up, and symptoms often persist for years beyond initial presentation. These sobering statistics underscore the chronic nature of patellofemoral pain for many individuals and argue against expectations of rapid, complete resolution. Patients should be counseled that improvement is expected with appropriate treatment, but that some degree of ongoing symptoms is common and does not necessarily indicate treatment failure. Factors associated with favorable prognosis include shorter symptom duration at presentation, lower baseline pain intensity, absence of psychological distress, and good early response to treatment. Conversely, longer symptom duration, higher initial pain levels, elevated fear avoidance beliefs, and limited early improvement predict poorer outcomes. Recognition of these prognostic factors enables identification of patients at risk for persistent symptoms who may benefit from more intensive or multimodal treatment approaches. Now let's move into Module 7 on integrated case studies. The final module of this course presents case studies that integrate concepts from all preceding modules. These cases illustrate the clinical reasoning process from initial evaluation through treatment selection, progression, and outcome assessment. Each case represents a distinct patient presentation requiring individualized application of evidence-based principles. The goal is to demonstrate how the theoretical and research knowledge presented throughout this course translates into practical clinical decision-making. Clinical reasoning in patellofemoral pain involves hypothesis generation based on available information, systematic testing of hypotheses through examination, identification of dominant contributing factors, and selection of interventions targeting those factors. This iterative process continues throughout treatment as new information emerges and patient response guides ongoing decision-making. Effective clinical reasoning integrates population-level evidence with individual patient characteristics to optimize outcomes. Case Study 1 presents a 16-year-old female high school soccer player with bilateral anterior knee pain of 6 months duration. She reports pain with running, jumping, squatting, and prolonged sitting. Pain intensity averages 5 out of 10 and increases to 7 out of 10 during soccer practice. She has continued playing through pain but notices declining performance and has recently begun avoiding certain drills due to symptoms. She expresses frustration with her condition and worry about her upcoming club soccer tryouts. Initial examination reveals a healthy-appearing adolescent female at Tanner stage 4 who reports menarche at age 13. She demonstrates moderate bilateral dynamic knee valgus during single-leg squat, with the left side more pronounced than the right. Hip abductor strength testing reveals weakness bilaterally at 4 out of 5, with the left weaker than the right. Quadriceps strength is symmetric at 4+ out of 5 bilaterally. Patellar mobility is normal, and there is no effusion. Palpation reveals diffuse parapatellar tenderness bilaterally without focal areas of maximum tenderness. Hamstring flexibility is moderately limited bilaterally. Fear avoidance screening reveals elevated kinesiophobia with a Tampa scale score of 42, indicating significant movement-related fear. She describes worry that continuing to play soccer might cause permanent damage to her knees. Her Kujala anterior knee pain scale score is 68 out of 100, indicating moderate functional limitation. She has not received any prior treatment for her symptoms beyond over-the-counter analgesics and activity reduction. The clinical reasoning process for this case begins with synthesis of examination findings to identify dominant contributing factors. The bilateral presentation with diffuse parapatellar pain reproduced by patellofemoral loading activities confirms the diagnosis of patellofemoral pain syndrome. The absence of focal tenderness, effusion, or instability findings rules out primary patellar tendinopathy, fat pad impingement, or patellar instability requiring different management. The normal patellar mobility suggests that lateral retinacular tightness is not a primary contributor. 3 dominant contributing factors emerge from the evaluation. First, bilateral hip abductor weakness contributes to the observed dynamic knee valgus during functional activities. Second, limited hamstring flexibility may alter knee mechanics and increase patellofemoral loading. Third, elevated fear avoidance beliefs represent a psychosocial factor that may perpetuate symptoms and impede recovery. Treatment planning should address all 3 factors for optimal outcomes. The treatment program begins with patient education addressing the nature of patellofemoral pain and the rationale for active rehabilitation. Importantly, education should directly address her fear that continued activity causes damage. Explaining that hurt does not equal harm and that gradual, progressive loading actually promotes tissue health can begin to modify maladaptive beliefs. This education sets the foundation for engagement with the active treatment components that follow. The exercise program addresses the identified physical impairments through combined hip and knee strengthening. Hip-focused exercises include side-lying hip abduction, clamshells with resistance band, and standing hip abduction. Knee-focused exercises include terminal knee extension, straight leg raises, and partial wall squats within pain-free range. Initial exercise intensity is set at a level that produces no more than 2 out of 10 pain during and immediately after exercise. Hamstring stretching is incorporated to address the identified flexibility deficit. Static stretching of 30 seconds duration performed bilaterally following exercise sessions targets improved muscle extensibility. Active hamstring stretches, such as the supine active knee extension stretch, provide a dynamic option that may better prepare tissues for athletic activity. Flexibility gains typically require consistent practice over 4 to 6 weeks before meaningful improvements occur. Psychologically informed treatment components address the elevated kinesiophobia identified during evaluation. In addition to the initial education provided, graded exposure to feared activities is implemented. The patient identifies specific activities she has been avoiding, which are then ranked from least to most anxiety-provoking. Systematic exposure begins with less threatening activities and progresses as confidence builds. This approach directly targets fear avoidance while building self-efficacy through successful experiences. Activity modification during the initial treatment phase balances symptom management with maintenance of athletic identity and fitness. Complete rest is not recommended given evidence that continued activity with intolerance promotes better outcomes than cessation. Instead, the patient modifies soccer training to reduce provocative activities while continuing participation. Specifically, she reduces jumping and sprinting volume while maintaining technical work and moderate intensity running. This approach maintains her connection to the sport while allowing symptoms to settle. Treatment progression follows principles of gradual loading based on symptom response. Exercise intensity increases as tolerance permits, progressing from isolated open-chain exercises to integrated closed-chain movements. Single-leg exercises including step-ups, single-leg squats, and lunges challenge neuromuscular control in positions that more closely replicate athletic demands. Visual feedback using a mirror helps the patient maintain proper alignment and reduces dynamic valgus during these challenging exercises. Sport-specific rehabilitation prepares the patient for return to full soccer participation. Progression includes straight-line running, change of direction drills, jump landing training, and eventually full practice integration. Each phase is advanced only after successful completion of the preceding phase without significant symptom exacerbation. The target is returned to full participation in soccer with minimal symptoms and restored confidence, ideally prior to the club soccer tryouts that represent her primary goal. Outcome assessment at 8 weeks demonstrates meaningful improvement across multiple domains. Her Kujala score has improved from 68 to 84, exceeding the minimal clinically important difference of 10 points. Her Tampa scale of kinesiophobia score has decreased from 42 to 28, indicating substantial reduction in movement-related fear. Hip abductor strength has improved to 5 out of 5 bilaterally, and dynamic valgus during single-leg squat has notably improved. She has successfully returned to full soccer practice and reports pain averaging 2 out of 10 during activity, down from 7 out of 10 at baseline. This case illustrates several key principles from the course content. The comprehensive evaluation identified multiple contributing factors spanning biomechanical and psychosocial domains. Treatment addressed all identified factors rather than focusing exclusively on physical impairments. The psychologically informed approach was essential given her elevated kinesiophobia, which if unaddressed would likely have impeded rehabilitation progress. Activity modification balanced symptom management with maintenance of sport participation. Outcome assessment confirmed meaningful improvement and guided the return to sport progression. Case Study 2 presents a 34-year-old male recreational runner with insidious onset left anterior knee pain of 3 months duration. He reports pain primarily during and after running, with symptoms worsening over the past month as he increased training volume in preparation for a half marathon. Pain intensity is 3 out of 10 at rest and increases to 6 out of 10 during running, forcing him to cut runs short. He denies symptoms with daily activities and has no pain with prolonged sitting. He has no prior history of knee problems and denies any traumatic onset. Examination reveals a fit-appearing male with no observable lower extremity malalignment. Single-leg squat demonstrates minimal dynamic valgus bilaterally with good neuromuscular control. Hip abductor strength is 5 out of 5 bilaterally. Quadricep strength is 5 out of 5 bilaterally with no pain provocation. Patellar mobility is normal without evidence of lateral tilt. Palpation reveals mild tenderness along the lateral patellar facet on the left without tenderness at the patellar tendon insertion. There is no effusion. Flexibility assessment reveals bilateral gastrocnemius tightness with ankle dorsiflexion measuring 5 degrees bilaterally. Running gait analysis on a treadmill at his typical training pace reveals a step rate of 156 steps per minute, which is below the commonly recommended threshold of 170 to 180 steps per minute. His stride length appears long with notable heel striking and extended knee at initial contact. Peak knee flexion during stance phase appears excessive. Fear avoidance screening with the Tampa scale yields a score of 22, indicating minimal kinesiophobia. His Kujala score is 82, consistent with mild to moderate functional limitation specific to running activities. Clinical reasoning for this case identifies running biomechanics as the dominant contributing factor. Unlike the adolescent soccer player, this patient demonstrates good hip strength and minimal dynamic valgus during clinical examination. His symptoms are specifically tied to running rather than general patellofemoral loading activities. The low cadence and long stride length identified during gait analysis suggest excessive patellofemoral loading during running that may exceed tissue tolerance, particularly in the context of recent training volume increase. The treatment approach for this patient centers on gait retraining to reduce patellofemoral joint loading during running. The target cadence is calculated as 110% of his baseline rate, yielding a goal of 172 steps per minute. He is instructed to use a metronome application set to this cadence during running and to match his foot strike to the beats. Initial practice occurs during short, easy runs to allow adaptation to the new pattern before applying it during longer or more intense sessions. Gastrocnemius stretching addresses the identified ankle mobility limitation that may contribute to his heel striking pattern. Improved ankle dorsiflexion can facilitate a midfoot strike pattern that naturally accompanies the increased cadence. Wall stretches and eccentric calf drops perform daily target improved flexibility. The combination of increased cadence and improved ankle mobility should produce the desired gait changes that reduce patellofemoral loading. Case Study 3 presents a 28-year-old female recreational athlete with chronic bilateral anterior knee pain of 18 months duration. She reports pain with stairs, squatting, prolonged sitting, and any impact activities. She previously enjoyed running, hiking, and group fitness classes but has progressively reduced all physical activity due to pain and fear of worsening her condition. She has seen multiple healthcare providers and received various diagnoses including runner's knee, chondromalacia, and patellar malalignment. Previous treatments including rest, anti-inflammatories, patellar taping, and a generic quadriceps strengthening program have provided only temporary relief. Examination reveals diffuse bilateral parapatellar tenderness without focal areas of maximum pain. There is no effusion and patellar mobility is normal. Interestingly, physical examination findings are relatively modest, with only mild hip abductor weakness at 4+ out of 5 and minimal dynamic valgus during single-leg squat. She demonstrates apprehension and guarding during provocative testing that appears disproportionate to the mechanical findings. Pain behaviors including grimacing, breath holding, and protective limb withdrawal are notable throughout the examination. Psychosocial screening reveals markedly elevated scores. Her Tampa scale of kinesiophobia score is 58, indicating severe movement-related fear. Her pain catastrophizing scale score is 34, well above the clinically significant threshold. She describes her knees as damaged and fragile, believes that activity will cause further deterioration, and has organized her life around avoiding knee-loading activities. Her Kujala score is 52, indicating substantial functional limitation that appears disproportionate to her relatively mild physical findings. The clinical picture suggests that psychological factors, particularly fear avoidance beliefs and pain catastrophizing, are primary drivers of her ongoing disability. Treatment must prioritize these psychosocial factors alongside, or even before, physical rehabilitation. A graded exposure approach combined with pain neuroscience education represents the evidence-based strategy for this presentation. Treatment for this complex chronic presentation requires a fundamentally different approach than the preceding cases. Attempting to address mild physical impairments through traditional strengthening programs is unlikely to succeed when powerful psychological barriers prevent engagement with therapeutic exercise. The treatment priority is modification of maladaptive beliefs and reduction of fear avoidance behavior through psychologically informed rehabilitation strategies. Pain neuroscience education forms the foundation of treatment. This educational approach explains the neurobiological mechanisms of chronic pain, emphasizing that pain does not necessarily indicate tissue damage and that the nervous system can become sensitized to produce pain disproportionate to any ongoing tissue pathology. Understanding these concepts helps reframe her experience from one of fragile, damaged knees requiring protection to one of a sensitized pain system that can be gradually desensitized through appropriate activity exposure. Graded exposure systematically addresses avoidance behaviors that maintain her disability. A hierarchy of feared activities is constructed, ranking from least to most anxiety-provoking. Exposure begins with activities that produce minimal fear and progresses gradually as each level is mastered without the feared consequences occurring. Each successful exposure provides evidence that contradicts her catastrophic beliefs, gradually building confidence and reducing fear. This approach is more powerful than reassurance alone because it provides experiential learning that cannot be dismissed. The graded activity progression for this patient might begin with short walks on flat ground, which she currently tolerates with mild anxiety. Success at this level, demonstrated by completing walks without worsening symptoms or feared consequences, enables progression to slightly longer walks. Subsequent levels introduce gentle inclines, brief stair negotiation, and eventually partial squatting activities. The key principle is that each level is practiced until anxiety diminishes before advancing, which may require multiple successful repetitions. Traditional strengthening exercises are introduced once fear avoidance beliefs have moderated sufficiently to permit engagement. Initial exercises are framed as movement exposure rather than strengthening, emphasizing the safety of progressive loading rather than targeting specific muscle groups. As confidence builds and exercise tolerance improves, programming can become more traditional with progressive resistance and functional exercise integration. The physical and psychological components of treatment ultimately become integrated as the patient recognizes that she can load her knees safely and that doing so produces beneficial effects. Consideration of referral to psychology or psychiatry is warranted for patients with severe psychological involvement. While rehabilitation professionals can effectively deliver pain neuroscience education and graded exposure within their scope of practice, some patients benefit from more intensive psychological intervention. Collaborative care involving both rehabilitation and mental health professionals optimizes outcomes for complex chronic pain presentations. The rehabilitation professional should maintain close communication with mental health providers to ensure coordinated treatment planning. This case illustrates the critical importance of comprehensive evaluation, including psychosocial assessment. Had treatment focused exclusively on the mild physical impairments identified, failure would have been highly likely given the overwhelming contribution of psychological factors to her presentation. Recognition that fear avoidance beliefs and pain catastrophizing were primary drivers enabled selection of appropriate treatment strategies targeting these factors. The contrast between this case and the runner in case study 2 highlights the heterogeneity of patellofemoral pain. Both patients carry the same diagnosis, yet optimal treatment differs fundamentally. The runner's symptoms relate primarily to biomechanical loading during a specific activity and respond well to gait modification. This patient's symptoms are maintained primarily by psychological factors and require psychologically informed intervention. Individualized evaluation that identifies dominant contributing factors for each patient enables treatment matching that optimizes outcomes. The prognosis for this chronic, psychologically complex presentation is more guarded than for the acute presentations in the preceding cases. Meaningful improvement is achievable but typically requires longer treatment duration and may not achieve complete symptom resolution. Setting realistic expectations helps prevent discouragement when progress is gradual. Celebrating incremental gains in function and quality of life, rather than focusing exclusively on pain intensity, maintains motivation throughout an extended rehabilitation course. We will now review the exam questions to solidify your understanding of patellofemoral pain syndrome concepts covered in this course. Question 1. What modifiable risk factor has been consistently identified as associated with the development of patellofemoral pain in military recruits and athletic populations? The correct answer is A. Knee extensor weakness. Research examining predictive factors for patellofemoral pain has consistently demonstrated that baseline quadriceps weakness is a significant modifiable risk factor. Meta-analyses of prospective studies in military populations have shown that recruits with weaker knee extensor strength at entry are more likely to develop patellofemoral pain during training. This finding is clinically significant because it represents a modifiable factor that can be addressed through targeted strengthening programs. Unlike anatomical variants or structural factors, quadriceps strength can be improved with appropriate exercise intervention, making pre-participation screening and preventive strengthening valuable strategies for at-risk populations. The quadriceps play a critical role in controlling patellar tracking and distributing loads across the patellofemoral joint, which explains why weakness in this muscle group predisposes individuals to pain development. Question 2. When differentiating patellofemoral pain from patellar tendinopathy, which clinical finding is most characteristic of patellar tendinopathy? The correct answer is B. Focal tenderness at the inferior pole of the patella that patients identify with a single finger. Rationale: the distinction between patellofemoral pain and patellar tendinopathy is an essential differential diagnosis skill for clinicians. Patellar tendinopathy, sometimes called jumper's knee, characteristically produces pain localized specifically to the inferior patellar pole where the patellar tendon originates. Patients with this condition can typically point to their pain with a single finger, demonstrating the focal nature of the pathology. In contrast, patellofemoral pain syndrome typically produces more diffuse, periarticular discomfort that patients often describe by circling the entire kneecap with their hand. Additionally, while the theater sign, which refers to pain with prolonged sitting, is a hallmark of patellofemoral pain syndrome, it is not characteristic of patellar tendinopathy, which is more typically aggravated by jumping, landing, and other activities that load the tendon directly. Question 3. According to research on sex differences in biomechanics, which finding has been observed in females during single-leg activities compared to males? The correct answer is C. Greater contributions from hip adduction and internal rotation to dynamic knee valgus. Rationale: understanding sex-specific biomechanical differences is important for developing targeted assessment and intervention strategies. Research examining pelvis and lower limb kinematics has revealed that females tend to demonstrate greater dynamic knee valgus during single-leg activities compared to males. Importantly, the components contributing to this valgus pattern differ between sexes. In females, hip adduction and internal rotation make greater contributions to the overall valgus alignment during dynamic tasks. These proximal contributions from the hip create a more medially directed vector at the knee, potentially increasing patellofemoral joint stress. This finding has clinical implications for both injury prevention and rehabilitation, suggesting that exercise programs for female patients with patellofemoral pain may need to place particular emphasis on hip abductor and external rotator strengthening, as well as neuromuscular training to control frontal plane hip motion during functional activities. Question 4. What does current systematic review evidence indicate about exercise therapy approaches for patellofemoral pain? The correct answer is D. Combined hip and knee strengthening produces superior outcomes compared to knee strengthening alone. Rationale: the evolution of exercise prescription for patellofemoral pain has shifted significantly based on systematic review and meta-analytic evidence. While traditional approaches emphasized isolated quadriceps strengthening, current high-level evidence demonstrates that combined hip and knee strengthening programs produce superior outcomes. Specifically, integrating hip abductor and external rotator exercises alongside quadriceps strengthening leads to greater improvements in both pain and function compared to quadriceps-focused programs alone. This makes biomechanical sense when we consider the kinetic chain relationships between the hip and knee. Weakness in hip abductors and external rotators allows excessive femoral adduction and internal rotation during weight-bearing activities, increasing lateral patellofemoral contact pressures. By addressing proximal muscle function, we can improve lower extremity alignment and reduce abnormal patellofemoral loading during functional tasks. This combined approach has become the current standard of care based on the strength of the supporting evidence. Question 5. In the randomized controlled trial examining psychologically informed education for adolescents with patellofemoral pain, which outcome was demonstrated in the intervention group? The correct answer is A. Significant reductions in fear avoidance beliefs, kinesiophobia, and pain catastrophizing. Rationale: the biopsychosocial model of pain recognizes that psychological factors play an important role in the experience and perpetuation of musculoskeletal conditions like patellofemoral pain. Research has specifically examined the impact of psychologically informed education in adolescent populations, comparing it to standard educational approaches. The intervention group receiving psychologically informed content demonstrated significant improvements in multiple psychological domains, including reduced fear avoidance beliefs, decreased kinesiophobia, and lower levels of pain catastrophizing. Importantly, these improvements in psychological measures were accompanied by better functional outcomes and greater pain reduction compared to the control group. This evidence supports the integration of psychological components into adolescent patellofemoral pain management, addressing not only the physical contributors to pain but also the cognitive and emotional factors that influence recovery trajectories and treatment adherence. Question 6. According to research on return to sport timing following medial patellofemoral ligament reconstruction, what was associated with increased incidence of anterior knee pain? The correct answer is B. Return to sport earlier than 9 months post-surgery. Rationale: return to sport decision-making following medial patellofemoral ligament reconstruction requires careful consideration of multiple factors, including timing. Research examining outcomes after this procedure has identified premature return to sport as a significant risk factor for developing anterior knee pain. Specifically, athletes who returned to sport earlier than 9 months following surgery demonstrated a significantly increased incidence of anterior knee pain, with approximately twice the odds of developing this complication compared to those who waited longer. This finding highlights the importance of allowing adequate time for biological healing, strength restoration, and neuromuscular recovery before resuming high-level athletic activity. Clinicians should counsel patients about these risks and utilize objective criteria, including strength, symmetry, and functional testing, to guide return to sport decisions rather than relying solely on arbitrary timelines. Question 7. When managing a patient with patellofemoral pain who demonstrates elevated fear avoidance beliefs and pain catastrophizing despite minimal physical examination findings, which treatment approach is most appropriate based on the biopsychosocial model? The correct answer is C. Graded exposure to feared activities combined with pain neuroscience education. Rationale. The biopsychosocial model recognizes that pain is a multidimensional experience influenced by biological, psychological, and social factors. When a patient presents with significant psychological distress, including elevated fear avoidance beliefs and pain catastrophizing, but minimal objective physical findings, treatment must prioritize these psychological contributors alongside physical rehabilitation. Pain neuroscience education helps patients understand the complex nature of pain and can reduce catastrophic thinking about activity and movement. Graded exposure involves systematically and progressively reintroducing feared activities in a safe, controlled manner, helping patients build confidence and self-efficacy while demonstrating that movement is safe. This approach addresses the cognitive and behavioral aspects of the pain experience, rather than focusing exclusively on tissue-based treatments that may reinforce unhelpful beliefs about structural damage. By combining education and graded exposure, clinicians can help patients develop adaptive coping strategies and return to meaningful activities. This concludes our review of the exam questions for this continuing education course on patellofemoral pain syndrome. We have covered key concepts including modifiable risk factors for developing patellofemoral pain, differential diagnosis strategies distinguishing patellofemoral pain from patellar tendinopathy, sex differences in lower extremity biomechanics, evidence-based exercise prescription emphasizing combined hip and knee strengthening, the role of psychologically informed education in adolescent populations, return to sport considerations following surgical intervention, and biopsychosocial management approaches for patients with elevated psychological distress. Understanding these concepts will help you provide evidence-based, patient-centered care for individuals with patellofemoral pain in your clinical practice.